ఎంతమంది వచ్చారు ఎట్ట తెలిసింది?
Madam, 48 participants now, including 4 of us, so 44 delegates.
They'll join in, I think, Sanjay.
For 5 minutes, madam.
Okay.
5 minutes. We'll wait and Susila madam.
Chapandi.
Screenshots తీస్తారా keyboard operation తో?
Screenshots
మీ కీబోర్డ్ మీద lowest panel మీద లెఫ్ట్ నుంచి రెండోది కంప్యూటర్ బొమ్మ ఉంటుంది చూడండి.
అవును.
అప్పర్ రైట్ సైడ్ ఆ నంబర్స్ పైన ఒక దాని మీద SYS సంథింగ్ అలా ఉంటుంది.
నేను అడుగుతాను ఒకసారి, అడిగి మా వాడిని అడుగుతాను.
రెండు కలిసి పట్టుకుంటే స్క్రీన్ షాట్ వచ్చేస్తుంది. కంప్యూటర్స్ లో పిక్చర్స్ లో సేవ్ అవుతుంది.
అవును అవును, ఒకసారి అడుగుతాను.
ఏమన్నావు శైలజ? ద విండోస్ లోగో పెట్టుకుని
విండోస్ లోగో అండ్ అప్పర్ బార్ లో SCR పబ్లిక్ సంథింగ్ సంథింగ్ ఒక 4 ఆప్షన్స్ ఉంటాయి ఒక బటన్ మీద.
FCR లేదే నా దగ్గర. ప్రింట్ స్క్రీన్
రెండు కలిపి ప్రెస్ చేస్తే స్క్రీన్ షాట్ మై కంప్యూటర్ లో పిక్చర్స్ లో సేవ్ అవుతుంది.
ప్రింట్ స్క్రీన్
మేడం,
ప్రింట్ స్క్రీనా?
ప్రింట్ స్క్రీన్ అను ఆ కంప్యూటర్ ది ఉన్నది.
స్క్రీన్ అండ్ కంప్యూటర్ ది రెండు కలిపి సైమల్టేనియస్లీ యు హావ్ టు ప్రెస్.
Okay, fine. I'll see later on.
Get a photo of the lab to your screen.
Okay. So we have reached the 50 landmark.
Yeah. 49.
Yes.
ఓపెన్ చేసావు కదా, నీ పేరు వచ్చింది కదా అక్కడ పార్టిసిపెంట్స్ లో చూడు. ఈ రోజే రాస్తా.
సునీత గారు అంటే పద్మజ గారు, ప్లీజ్ మ్యూట్ యువర్ సెల్ఫ్. Dr. Sunita Chennareddy, please mute yourself. Madam, shall we start?
Yeah, the 51. So.
Yeah, madam. They'll keep joining. We'll start.
Okay. Start చేద్దామా మరి? Sailja?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes.
Yeah. So good evening all. So I welcome each and everyone to this session on medical termination of pregnancy. This session is going to enlighten us on respectful abortion care. It is a joint venture of FOXI and WHO. So we all know that the newer MTP Act has come around like few months back. So this session will firstly cover the newer amendments, that is what is new in the Act. And this second session will cover the methods, both surgical and the medical methods which Dr. Padmaja is going to reiterate which is the best method at what gestational age. And third one is regarding the counseling part, that is talking to the patient about pre-abortion care, post-abortion care, contraception. And fourth one is regarding the respect, that is what are the terms we should use to respect them, and unbiased services that we are supposed to give to the client. So we shall start, and around like 50 have joined in. So we'll start the session. And the first talk is going to be on medical termination of pregnancy, the newer amendments. It is going to be done by Dr. Uma. She's a consultant of Rainbow Hospitals, Vijayawada. Over to you, Uma. Unmute Uma. Shailaja, you need to unmute, Shailaja. So today's 4 sessions, first one will be by Dr. Uma, the second one by Dr. Padmaja, third one will be by Dr. Supraja, and the fourth one again will be by Dr. Uma.
Uma madam, go ahead.
Full screen. You need to make it full screen, Uma. And I request all the doctors to be logged in till the end and also do the post test so that you can all receive the participant certificate.
Can you see full screen?
No, it is only, you have to make it full screen. It is only partial screen. Slideshow.
I don't know what's wrong.
We have 54 participants.
Can you see now?
No, have to make slideshow, Uma.
How many registered, Dr. Sailaja?
100.
Sailaja, unmute yourself.
Madam, 4 of us faculty are there and 50 delegates right now.
No. How many registered?
Registered 100, madam.
Yo, again it's the same.
They'll come, madam. They'll join.
Hopefully.
Yeah, it is full screen now, Uma. You can start.
Can you see? Hello?
Uma?
Madam, we can see, but this is not slideshow.
Maybe you can continue, Uma. This way.
I don't know. It's not working. It's going to mute itself when I'm out starting slideshow show.
Okay, then maybe you can continue in the same model.
Madam, Uma madam, if it's okay with you, Sriman can share the slide.
Yeah, it is full screen. Yeah, it is full screen, Uma. Unmute yourself, Uma. Unmute. Yeah, go ahead. Yeah, you can go ahead.
Can you hear me?
Yeah, a little, you need to talk a little.
Madam, this thing increase the volume.
You need to talk a little louder. Yeah, like, yeah,
Can you hear me now?
yeah, a little, come little closer to the laptop, better. Yeah,
Oh, yeah.
yeah, go ahead.
Work. Yeah, thank you, Dr. Susila. Now we're going straight into the topic, getting into the first topic of this RAC training program jointly organized by
Compulsory CME కాదు training program. Foxy registered members అందరూ WHO.
Shravanti, Dr. Shravanti, please mute yourself.
This is the first module of the RAC Respectful Abortion Care Training Program jointly organized by Foxy and WHO. We'll be discussing about MTP Amendment Act 2021, which is around us in some form or the other for quite some time. In the
Madam,
next 20
madam,
minutes,
very low volume, not audible. Can you please increase the volume? No, it's gone again. The screen has gone. Madam, you want Susila madam or Padmaja madam to share?
yeah, no issues we can do. Can you hear me now?
Yeah, madam, it is audible now. Padmaja madam, is
Can you,
it okay with you?
can you see the slides?
We can see it in slide format, madam, not full screen. I will try sharing the slides. You stop the sharing, please.
Okay, I stop.
Can you see now?
Yeah, I can see.
You tell me next, I will move ahead.
Yeah, okay. So in the next 20 minutes or so, I will be talking about the changes made in comparison to the previous act. What are the new rules for termination of pregnancy and what are the implications of such changes? This is a way to provide formal information about the new MTP Amendment Act. I will try to keep it as simple as possible, and any questions please post to the chat box and will be answered later. Now, first, was there a need for change to bring a new law? Yes. Unsafe abortion is third leading cause of maternal mortality. Next slide, please. Unsafe abortion is third leading cause of maternal mortality. 8% of maternal deaths in India are due to abortions. Worrying fact is that 2/3 of abortions are performed or deemed unsafe currently, possible because they're performed in unsafe place, untrained personnel, or by an unsafe method. Nearly half of the pregnancy-related deaths in women are or among the girls who are under 24 years. So, when is abortion considered safe? Abortion performed by an appropriate method suitable for that gestational age by a trained person and at a recognized and approved place within the law is considered safe. So, in the new MPP Amendment 2021, which has been, next slide, which has been mandated by law in March 2021, and rules have been framed and is in the form of a gazette on 25th of September 2021. So now we will be governed by the MPP Amendment Act 2021 and we have to follow these rules. What are the salient features of the MPP 2021 Amendment Act? In the previous version of the Act, we needed opinion of one registered medical practitioner for termination of pregnancy up to 12 weeks and 2 registered medical practitioners from 12 to 20 weeks. And there was no provision for medical termination of pregnancy beyond 20 weeks. With the new 2021 Amendment Act, new law states that opinion of one registered medical practitioner is enough for termination of pregnancies up to 20 weeks, and from 20 to 24 weeks, opinion of 2 registered medical practitioners are required. So what is the potential outcome and why this change? This is likely to increase the number of facilities, especially in public sector with like PHCs eligible for service provision up to 20 weeks. Next, the second salient feature is modification for vulnerable group of women. As per the previous act, MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of pregnant women. With 2021 amendment, they enhanced the upper limit of gestation from 20 to 24 weeks for vulnerable group of women. Now, who are these vulnerable group of women are also defined. I'll talk about that later at an interesting. And further enhancement for birth defects is also made. Termination of pregnancies with fetuses with birth defects which are not compatible with life. There is no upper limit and they have to seek the opinion of medical board. Now, what is the potential outcome? It is likely to increase the increase the access of safe abortion for vulnerable group of women. And also there are, as I mentioned, there are certain rules which defines who are the vulnerable group of women, like the violence victims or minors or rape victims, etc. The third salient feature is the modification of upper limit of gestational age for birth defects and congenital anomalies. As per the previous act, we were restricted to do termination of pregnancy only up to 20 weeks, even with a lethal congenital anomaly. Now, current modification don't give any upper limit of gestational age for termination of pregnancy. But if a woman is more than 24 weeks of gestation and fetus has substantial fetal anomalies, then a medical board opinion should be obtained. What is the potential benefit of this change is increase in access to safe and legal abortion services, who often seek services late beyond legal limit of termination of pregnancy, especially with improving ultrasound, late diagnosis of evolving congenital abnormalities which are, lethal or, which has substantial disabilities. So this change is likely to promote a safe abortion practices, thereby reducing unsafe abortions and the court cases. The next salient feature is the modification related to the marital status. Earlier law states that the condition of failure of contraception was applicable only for husband, married woman or her husband. With changing socio-cultural profile, this change was deemed necessary, and so condition of failure of contraception is extended for any woman or her partner. That means to say, even if the woman is unmarried, she can go for termination of pregnancy with the failure of contraception. So what is the benefit is increased access to safe and legal abortion for any women, irrespective of marriage status. Finally, there was a new clause for strengthening privacy so that women can have respectable abortion care. MTP regulation 2003 mentioned that information should not be disclosed except under authority of law, but with the new amendment, name and other particulars of any woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So for the time being in force, law is the current amendment 2021 law, and according to this, name and other particulars of the women should not be mentioned to anyone and should not be revealed outside, nor should be mentioned in the file case records. So what is the potential benefit? It increases the privacy and ensures confidentiality of the abortion seekers. So it's likely to increase the demand and safeguard the rights and dignity of the women, and ensure confidentiality and safety, decrease bias and stigmatization of the woman who is undergoing abortion. Next, so these are the salient features of the amendment. Any law which comes with a set of, these are the changes in the amendment, and this law also comes with a set of rules to be followed. So what are the new rules under the MTP Amendment 2022? There are certain predefined rules, and which we should all be aware of this and follow while we are providing abortion services. The Act, as I mentioned, defines who are the special or vulnerable category of women. What are the norms for what are the norms for the registered medical practitioner who can conduct a termination of pregnancy at different gestational ages? And also there are set of rules, powers, functions which the medical board as to what constitutes, who constitutes the medical board, and what are the powers and functions of the medical board. So coming to the rule 1, who are the special category of women eligible for medical termination of pregnancy? Now remember, this special category of women, medical termination of pregnancy can be conducted even beyond 20 weeks, but within 24 weeks. So women who are eligible for MTP between 20 to 24 weeks are again divided into 7 subclasses. 1, survivor of sexual assault, rape or incest. A woman with pregnancy in humanitarian settings, disaster and or emergency situations as declared by government. Change of marital status during the ongoing pregnancy, say like woman becomes a widow or a divorcee. Women with physical disabilities. Now this disability is again defined by Major Disability Act. So a major disability as per criteria under the Disability Act. Mentally ill women, including mental retardation, minors, when there is a fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So these are the subclasses of women under this special or vulnerable categories of women, and this group of women are eligible for termination of pregnancy beyond 20 weeks but within 24 weeks, and opinion of 2 registered medical practitioners are required. Now remember, you should remember this point, still the old rule of upper limit of termination of pregnancy of 20 weeks apply. Beyond 20 weeks, it's not a blanket change. 20 to 24 weeks is only for vulnerable group of women, and no upper limit of gestational age for MTP if there is a substantial fetal abnormality, subject to medical board opinion if more than 24 weeks. So you have to realize into which category the woman falls before you offer termination of pregnancy. Now the second rules made by the amendment is that this defines who is a registered medical practitioner and who is eligible to perform MTP at different gestational ages. Registered medical practitioner is defined in the old Act as MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which 5 done independently in a hospital. A practitioner who has completed 6 months of house surgency in obstetrics and gynecology. A medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, or a medical practitioner who has experience of at least 1 year of practice in obstetrics and gynecology. Now, this is a 1 RMP. Then opinion of 1 RMP is required for termination of pregnancy up to 20 weeks with the current amendment. 2 registered medical practitioners' opinion is required from 20 to 24 weeks, and opinion of medical board if beyond 24 weeks. Now, under the new rule, they even defined which registered medical practitioner can perform termination of pregnancies at different gestation ages. Under the new amendment 2021, an additional category of provider has been added for termination up to 9 weeks and only with medical method. A registered medical practitioner with experience in practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP with medical method of abortion under supervision of an RMP in a hospital established or maintained or a training institute approved for this purpose by the government. Now remember, this is only for medical method and this is before 9 weeks of gestational age. Next, till 9. Going to, these are the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational ages. So as I have mentioned, till 9 weeks, new criteria has been added, and there are 4 group of registered medical practitioners, and opinion of 1 RMP is enough to provide termination of pregnancy. Going on up to 12 weeks. Next, going on up to 12 weeks. Now here, there are 4 group of registered medical practitioners. 1, a practitioner who has assisted a registered medical practitioner in a performance with 25 cases of MTP, of which at least 5 have been done independently. or a practitioner who holds a postgraduate degree or diploma, or a practitioner who has completed 6 months of house surgency in obstetrics and gynecology, or a practitioner who has experience at a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now, till 12 weeks, again, opinion of one registered medical practitioner is enough. Next, beyond 12 weeks until 20 weeks, now there are only 3 groups of registered medical practitioner who can actually opine and perform a termination of pregnancy. A practitioner who holds a postgraduate degree or diploma, a practitioner who has completed 6 months of house surgeons in obstetrics and gynecology, or a practitioner who has experience at a hospital for a period not less than 1 year in the practice of obstetrics and gynecology. So here up to 12 weeks again, an opinion of one RMP is enough for termination of pregnancy. Next, we go beyond 20 weeks until 24 weeks. Remember, during this period of gestation, it is only for women who are under special or vulnerable group of women. And again, the same thing holds good as in 12 to 20 weeks. One practitioner who has a degree or a postgraduate diploma in obstetrics and gynecology, or a practitioner who has completed 6 months of house surgery in OG, or a practitioner who has experience at a hospital for a period of not less than 1 year in a practice of obstetrics and gynecology. But here, beyond 20 weeks, up until 24 weeks, opinion of 2 registered medical practitioners is required for termination of pregnancy. Beyond 24 weeks, there are 2 groups of registered medical practitioners. One is a practitioner who holds a postgraduate degree or diploma, or a practitioner who has an experience at a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. So only these 2 categories of registered medical practitioner are permitted to do termination of pregnancy. But before you go for termination of pregnancy, when it is beyond 24 weeks, you have to seek opinion and approval from medical board for termination of pregnancy. MTP should be performed only in an approved place with appropriate safety after thorough counseling. So, being throughout, this discussion, talking and telling you about medical board, this is a new term which came up with this amendment of the new law. So, what is a medical board? Who constitutes medical board? What are its duties and responsibilities? Medical board is formed by a gynecologist, a pediatrician, and a radiologist or sonologist. Board will also have one chairperson who can be a department HOD or superintendent. Medical boards is formed by concerned government authorities, say like district health authorities or some state government officials. As health is a state subject, it's responsibility of state governments to form medical boards, and we have to be aware of the medical board to whom we can refer if there is a patient who is beyond 24 weeks with substantial fetal abnormality. So what are the parts of the medical board? Medical board has right to allow or deny termination of pregnancy beyond 24 weeks of gestation, only after due consideration and ensuring the procedure would be safe for the woman at that gestational age. They will have to look into whether the fetal malformations has substantial risk of it being incompatible with life, or if the child was born would suffer from significant physical or mental disability or may be seriously handicapped. Whenever needed, medical board can involve other specialists and ask for additional investigations if required for deciding on termination of pregnancy. Other specialists say, for example, if there is a fetus with cardiac abnormality, they can involve a pediatric cardiologist. If there is a problem with neurological, genetics, they can involve a geneticist. So they can involve other specialists before they decide upon termination of pregnancy. FOXI with Ministry, Family Welfare Ministry is taking lead role to support respectful abortion care, and they are likely to put up what are the various medical boards on their website. So probably in the near future we can check on the FOXI website as what are the medical boards are available in our country. Next, what are the functions of medical board? Medical board has to examine or assist the woman with her reports, whoever approaches her for termination of pregnancy. Opinion of the medical board is to be written down on a form called Form D with regard to the termination of pregnancy. Let them accept or reject whatever. They have to opine on a form, and they have to refer back, reject the request for termination of pregnancy, and this has to be done within 3 days of receiving the request for termination of pregnancy. Now, when you find a patient with this fetal malformation or substantial fetal anomaly, you just write a letter to a medical board, and medical board have to opine or about termination of pregnancy within 3 days, and they have to send their opinion back in a form called Form D. And it's the duty of medical board to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of receipt of the request for medical termination of pregnancy. Now here, as FOGSI members of FOGS has an important role to play in ensuring that there are functions of the medical board in every state, and we will be aware of our state medical board shortly, likely in the next few weeks, and we have to follow next. So yeah, so this is in brief about the new amendment. What are the changes when compared to old law, and what are the rules that you should follow when you are doing the termination of pregnancy. For India, abortion is legal. Follow rules specified by law, and we can all work to make abortion safe and effective. Thank you.
Thank you, Uma. It was a lucid presentation. So we all should know what are the changes that have been brought in newer act. So we have to know what is the basic act also. That is the MTP Act 1971 and the changes that have been made, these 7-8 changes. So we all need to know what is that act and what are the changes so that we can have a legal free practice, litigation free practice. So the basically one of the questions, Uma, that has been in the chat box is can MTP be done in private clinic which is licensed after 24 weeks following medical board opinion? Uma, for you.
You can do MTP if it's your clinic is already.
We can't hear you, madam.
Approved to do a medical.
Yeah.
And as I have mentioned, beyond 20 weeks, there are only 2 classes of registered medical practitioners who can perform: a postgraduate degree holder or a diploma holder, and an experience in OG for more than a year.
Okay, so I shall add one more point to it, Uma. The thing is, after 24 weeks, definitely it is a risky pregnancy. That is, after 24 weeks, it comes to second trimester. So it has to be done in a safe place, and also the medical board would suggest which place it has to be done. So it cannot be done in a clinic. Yeah. So that I would add.
Only after opinion from medical board.
Yeah. And also they would suggest the place and see that everything goes safely.
Yeah, it's duties of medical board to see that abortion is done safely.
Yeah.
So, Uma madam, Dr. Badhu here. Ma'am, confidence they are asked to keep the patient's name not to be disclosed, right? But if a patient, now if on medical board opinion, if you're terminating a lady who is beyond 24 weeks, it becomes like a mini labor. In that case also you need to keep the name of the patient hidden?
Yes,
Anytime. And other point is we need not know the marital status. If a patient comes for an abortion, we need not ask whether she is married or not. We are supposed to do, the services should be unbiased. There is no need to ask about their marriage. And we have to keep everything confidential. Nothing should be open. Only the file number should be there, admission number. Yeah, we have to follow that. That has been clarified by the seniors also.
Yeah. So suppose in a hospital there is a board, kind of in the labor ward, and some people note have a habit of writing on the board. You should avoid that. You shouldn't write the patient's name, age, or whatever, and about the termination aspects on the board. Nowhere.
Okay, madam. Okay. Thank you.
Okay. So we shall move on to the next session. It is regarding the safe abortion medical and surgical methods, and this is going to be done by Dr. Padmaja. Over to you, Padmaja.
Just a moment.
Yeah. In case of any queries, please post in the chat box. So definitely the speakers would answer the questions.
Good evening, everyone. Thank you, Susila, for getting the ball rolling and Uma for starting off. In this module, we are looking at the updates in technology, and here we're going to look at the existing guidelines, the pre-abortion assessment, the medical methods of abortion, and the surgical methods. All these books are available on the net, the WHO guidelines for safe abortion. Anyone interested can go through the whole thing. There have been a lot of publications from 2012 in WHO, and we also have national publications which you can read. They are the roadmap for safe abortion. Law was changed on March 25th, 21, and the rules changed on 24th September. And what we want is a comprehensive care. So that is mandated by the law. In this, there are three key areas of management: pre-abortion care, what we are supposed to do before we start, during the abortion, and after care and follow-up, which includes contraception and counseling. So in the decision making about how we are going to do, for whom we are going to do, where we are going to do, we have to have, like any other assessment of a woman, a medical history, physical examination, lab investigations. So in the pre-abortion assessment and counseling, as I was telling, we need to have a detailed history because we need to be sure about the period of gestation. So we need to know her previous menstrual cycles and the LMP. Just because she came for a termination, it does not mean that quite large number of times women don't know about their health status. So we should not be missing any asthmas, cardiac conditions. We need to do a pelvic examination. You cannot go ahead without doing that. Lab and other investigations are supportive, and all these help us in the decision making for the abortion process and what we are going to counsel. Determining the LMP by gestational age, determining the gestational age is by LMP and physical examination. So we need to do a per-vaginal examination. If it is not, uterus is not palpable, because after 12 weeks, uterus should be palpable. And we measure the fundal height and check out how it goes. And this is one of the basic things that are taught in our MBBS values. The limitations of dating with examination and checking out the uterus sizes, sometimes fibroids, malformations can be there, multiple gestations can be there. Sometimes the uterus is markedly retroverted. In obesity, you can hardly make out the size, and molar has a bigger uterus than what the period of gestation is. If it is smaller, the woman might not be pregnant. She might just have missed her period. It could be an inaccurate dating or ectopic. And as we know, with the larger uterus, it could be an inaccurate dating, multiple malformations, and a molar pregnancy. Although routine tests are not a prerequisite, when we are in doubt, we need a urine pregnancy test. When she looks pale, we need to know the hemoglobin status, and we need an RH, because in RH negative, not giving an immunoglobulin will compromise her obstetric history for life. HIV testing and counseling can be done. We can use this opportunity to do that. And if we think in a pelvic examination there is a chance of sexually transmitted infection, we need to do further testing. And whenever the medical history says the normal, we might need kidney function test, liver function test, thyroid test. As ultrasound is not mandated by the law, but when you suspect an ectopic or a missed abortion, you need to do that. What do we do when a lady walks in is a pre-abortion counseling? What we need to know is gently probe. there is no hard and fast rule. We don't really need to go into all her personal reasons, but what are her thoughts about termination? Is she very ambivalent? Is she doing it because she does not want it, or is it being forced on her? Is something we need to determine. And we need to inform her that early abortion is safe. It is important that a trained provider uses the appropriate method. And we need to warn her about the risks and what are the problems that can occur with that. And we need to also put in a point telling that without contraception, after the termination, she can become pregnant within 14 days. And when she can resume her normal sexual activities, and what are the other follow-up care. If she's anemic, we do counsel them to continue their iron supplementation. After talking to her, we need to have a documentation of the written content and mention on that document whether she is willing to use some method for a post-abortion contraceptive. Even if she is not willing to take up a contraception, we need to go ahead and provide the abortion services. Up to 9 weeks, medical methods of abortion are what are necessary. If we consider in 7 weeks, if it's only a 49 days, up to 49 days, mifepristone, wait for 24 to 48 hours. Misoprostol can be given sublingual, buccal, vaginal, and oral. If it is between 49 and 63 days, 7 to 9 weeks, the same procedure, other than the fact that oral misoprostol cannot be used because it is not so effective. So misoprostol is sublingual, buccal, or vaginal. At less than 12 weeks, more than 9 weeks, we can offer them mifepristone, misoprostol, only misoprostol or vacuum. More than 12 weeks, the same thing goes ahead, but we can't do a vacuum aspiration. We need to do a dilatation and evacuation. All procedures, we need to remember that we don't need to do a check curettage because that causes more harm than good. So in the first trimester, we can either use medical methods or surgical. And mifepristone is an antiprogestin which inhibits progesterone, interferes with the continuation of pregnancy, and the first oral dose is followed by misoprostol, which is a prostaglandin E1 analog, which causes cervical softening, contraction, and expulsion of the products. The protocol is that along with mifepristone in an Rh negative woman, give anti-D. If we don't, as we don't have 50 mics, we can give 150, or if that is not available, give the whole 300. After mifepristone, day 3, as I was telling you, 400 mics of misoprostol up to 7 weeks and 800 in 7 to 9 weeks. If they complain of a lot of, we can give them analgesics, antiemetics, and also offer contraception. Follow-up is after 2 weeks to ensure the completion of the procedure and reinforce the contraception advice. Different routes of misoprostol can be used. Oral are only up to 7 weeks. The problem with this is, although many women prefer oral, once we tell them that there is increased incidence of fever, chills, nausea, and diarrhea, they might be okay with vaginal because it has the lowest side effects. Vaginal pills are placed in the fornix and the woman is instructed to lie down for 30 minutes. The other routes are buccal, where the pills are and sublingual. I'll just show you the picture. Both of them have more fever, chills, diarrhea. Sublingual is the fastest route of action with the highest plasma concentration level. In buccal, it is kept between the gum and the cheek. In sublingual, it is placed right under the tongue. So as we were telling you, This is the summing up of the regimens. Vaginal bleeding for 2 weeks is normal, and in rare cases, it can last up to 45 days. The advantage of medical methods of abortion is that it can be available at even a primary care level, but they have to have a referral system for higher level if there is problem. And using this opportunity when a woman comes in for abortion early, we can test and counsel regarding sexually transmitted diseases. If we have any suspect and a woman confides in us, we can give her abuse support and psychological, emotional support. And if we pick up any health problems, we can refer them for a specialist or medical services. Definitely iron for anemia and provide emotional support if necessary, and pain medications. Follow up in a very early, it is not totally necessary, but it is recommended if only misoprostol is given. And the follow-up visit helps us provide contraception counseling and not only counseling, we can give them the contraception, address their medical concerns, and give emotional support. So what do we do in the follow-up care? We see her recovery, look for signs and symptoms of ongoing pregnancy. If previously they have not brought their medical records, they have brought them now, we can have a look at them. Talk to them about how the whole experience was, and if there is any complaint, look into it physically. And all the time, our aim is to find out her fertility goals and talk to her about contraception. To summarize, for medical methods of abortion, on day 1, we do a physical examination, pelvic examination, confirm the eligibility that it is only up to 49 days, give mifepristone and anti-D. After 2 days, she comes back for misoprostol. We give her a contact address and phone number where she can come in case of an emergency, record her experience and side effect. 3% of women can expel completely with mifepristone, but we never are sure because it is only 3%. That means most of them won't. Misoprostol should be given in the according to the schedule to ensure the completion. Visit on day 3, give mifepristone, observe for 4 hours. If she is very sensitive, we can give her ibuprofen. Talk to her about contraception, tell her that the bleeding can last from 8 to 13 days. The medications can cause nausea, vomiting, diarrhea, headache, fever, dizziness. Just inform that so that she doesn't panic. But we need to also tell them if there is excessive bleeding, excessive pain, fever that is persistent, high grade, they need to come back to us. And we also need to tell them that within 24 hours after misoprostol, if they have absolutely no bleeding, they need to come back because they might need another dose of misoprostol. Most of the women, we can tell them that within 4 to 6 hours, most of the people abort and they will see bleeding. 2 weeks later, at the 3rd visit, an examination is necessary to check for completion. Provide contraceptive method, whatever she's willing to use. Inform her that immediate return to fertility is there. That is the reason we are talking about contraception at every step. And within 6 weeks after the abortion, if she is not having her period, we need to reassess, because sometimes if they don't use contraception, she can become pregnant again. And ultrasound examination only if we have serious doubts about the completion of the procedure. Side effects and complications we are looking for is that we talk to them and tell them that nausea, vomiting are self-limiting, diarrhea is self-limiting. But if we suspect the infection, confirm it and start antibiotics. Most importantly, when women complain of pain, we need to understand that each person has a different pain sensitivity, and their emotional status when they're going through this changes the pain perception. Therefore, our support and counseling is necessary. Talk to even her support person, give ibuprofen, and if there is persistent pain, we need to rule out something like an ectopic infection and an incomplete abortion. So if the procedure fails or it is incomplete, we can either repeat the medical method or offer vacuum aspiration. If it is incomplete, unless there is heavy bleeding, we can observe, because usually bleeding resolves and uterus comes back to normal size. We can repeat a misoprostol, or we can offer a surgical method. But if the heavy bleeding continues where she feels it's much, much heavier than her menstrual cycle, soaking 2 pads in our for more than 2 hours, we need to look at the vitals, do a pervaginal examination, see if the products are of conception are there in the cervix, where we can do a digital evacuation. If she is stable, we can monitor her and send her. If the bleeding after by the time she comes to us decreases over time, we can just keep a routine care on her vitals. If the bleeding continues, an ultrasound is necessary, and minimum decidual bits, we can wait and watch. She is stable, we see lots of products, we can give misoprostol, oral or sublingual. Any patients whose vitals are not stable, we don't have time, we need to do a vacuum aspiration. If it is a continuation of pregnancy, a vacuum aspiration. Recording and reporting is very important, even for medical abortion services, because it comes under the purview of the MTP Act. So we need to fill in the consent form, which is Form C, the opinion form, Form 1. We have Form 2, which is a monthly reporting form to be sent to the district authorities, and we need to have an admission register for the case records. All these, we should not be mentioning the name of the patient, and it should be kept confidential. Regarding surgical methods, we can use either manual vacuum aspiration or electrical. Vacuum aspiration can be used up to 12 weeks. WHO also says the manual vacuum aspiration is one of the safest. But once more, I'm informing that we don't need to do a sharp curettage. In manual vacuum aspiration, we assemble the whole aspirator, and the size of the cannula depends upon the size of the period of gestation. So whatever the cannula size, that gestation, 8 mm cannula for 8 weeks, 10 for 10. And electric, of course, we use suction machine. And cervical priming helps prepare the cervix, make it soft and easy to dilate. So before the surgical abortion of the first trimester, we can give oral mifepristone 24 to 48 hours. Meso 400, sublingual 2 to 3 hours prior, or vaginal 3 hours prior, or we can place a laminaria tent 6 to 24 hours prior. All procedures where we are using vacuum aspiration are painful, so it is important to reduce the anxiety by providing psychological support, explaining every step in advance, doing the procedure gently, telling her to relax and breathe deeply. And if they are extremely anxious, we can give anxiolytics. Of course, general anesthesia needs a huge setup. And this will need, if you are using diazepam, the effect will last for 4 to 6 hours. So there will be disorientation and dizziness. We need to keep them later on till they recover fully. Local, we can give 10 ml 1% xylocaine, 60 to 90 minutes, effect will be there. And Brufen 800 1 hour prior to the procedure also helps, unless, but the side effect of gastritis they will have to put up with. And in vacuum aspiration, you first close the button, clear, create a vacuum, make sure that she is comfortable, get the woman to empty her bladder, and clean the vagina and the cervix with antiseptic in a anti-clockwise direction. Give paracervical block, dilate the cervix, insert the cannula, and stay 1 to 2 centimeters away from the fundus. Rotate the cannula from the 10 o'clock to the 2 o'clock in a gentle motion. Release the vacuum, and we know we can stop and know that the uterus is empty when there is red or pink foam without any further tissue coming into the cannula. There is a gritty sensation and cervix grips the cannula, and there will be increased cramping. Most importantly, we need to inspect the tissue, have in a clear bowl, have light, check for trophoblastic tissue. And if the woman has agreed, we can have an IUCD insertion at the same time, or a tubectomy if they want it. Cleaning, the instruments need to be soaked in dilute chlorine, which helps disinfection, remove the tissue and the body fluids. Post procedure care, we need to monitor for complications. She can leave the facility if she is stable and meets the criteria for discharge. All women, we need to ensure that they have the necessary information and medication, and document all the outcomes, including any adverse side effects, in the register in the hospital and in the client's record. Aftercare, we need to be ready to deal with complications of incomplete infection or ongoing pregnancy. As we are telling again and again, every opportunity, we should be giving them contraceptive information and counseling and all the methods that are available, and assess their sexual and reproductive health needs. And the new recommendation is that meso alone regimes, we don't really need to do a follow-up. But follow-up, I personally recommend, because continuity of care and support for these women is necessary. To summarize, India has made historic progress in improving access to safe abortion. Technology has not changed much, but what is important is that we ensure safety and quality in the amended law with respect to abortion services. And every client use this as an opportunity to inform, educate, and give proper information and dispel myths regarding contraception and counseling. You've already done the registration and the pre-test. Do fill the post-test and give the feedback. So India, we are one of the few countries where abortion is legal. So let us make it safe and respectful. Good reproductive health outcomes. Thank you for listening.
Thank you, Dr. Padmaja. It was really a lucid presentation. You have covered all the aspects. Ajay sir is with us. Sir, can you just say a few words?
Thank you so much, Shailaja, Sheila, and Padmaja. You are the absolute torch bearers and people who are making and ensuring the flag for your society is flying extremely, extremely high. It's not just here in this program, but also Dhira, where you all have, you're miles ahead in terms of any other society or any other, city or state.
Thank you, Ajay. Your constant encouragement and support helps us going. And of course, we have Shailaja who's working.
Shailaja is working so hard.
I really can't count the number of times I have called Sriman. Hundreds of times I call him, he immediately responds and solves my problem.
Yes. That's what he's extremely a great guy to help all of you all. And on that note, dear colleagues, I, on behalf of FOGSI and on behalf of Respectful Abortion Care, which is a WHO and FOGSI program led by our very own President, Dr. Shanta Kumari, thank you very much for being so keen and to be participated participating in this particular workshop. And it is the second one that is being hosted by the society now. And a third one is also coming up shortly in a couple of days. And I must say the team here has been extremely vibrant, which I put down in the chat box also. And I can see a lot of close-knit, association amongst all of you all to be so vibrant, so proactive, and making sure you are participating in every program that the society hosts or the team members host. And a huge congratulations to all the faculty, because each one I can see is constantly at it and doing the job. Particularly, I need to, although the program is RAC, I also need to mention about Dhira, where you all have done fantastically well. We have covered almost about 7,000 children so far, all India. And out of that, almost 1,400 will be only from your society and the ones you have taken forward. I don't know how you do it, but trust me.
Teamwork.
Trust me,
Yeah.
I need to tell to all the society members here, trust me, that I have, so far we have done about 125 programs, all put together, RAC and Dhira put together. And out of those 125 programs, I have attended personally almost about 110, So listening is one thing which, there's a listener's fatigue also. I don't know how faculty fatigue is not setting in when you have to teach the same slide every time over and over again. But I see you're kind of mixing, matching, and making sure, that is not setting in. So huge congratulations once again. Please carry on and continue with the good job that each one of you have done. And Shailaja will be posting the post-test and feedback in the chat box at the end of the training program, so that you can click on it and submit the same and become eligible for your certificate. In case you missed the chat box, when you leave the meeting, again there will be a pop-up in which you click continue, and then you'll be taken to the post-test and feedback. With that, back to you.
Thank you so much. So thanks, Dr. Padmaja.
We'll go ahead with lots of questions in the chat box.
Yeah. So the one question Dr. Saujanya has asked is, whom from should we take consent in case of MTP in minors or unmarried and in married women? So Dr. Uma?
Yeah, it's already there. Any major who is willing to take responsibility, not necessarily parents, a guardian or parents, whoever, an adult who is willing to take responsibility should sign on their behalf.
Yeah. So this amendment has been made in the newer act that anyone can sign irrespective of the relation to the patient. Yeah. And other question is husband consent compulsory in case of MTP in married women?
No.
Yeah. So it is irrespective of the marital status, the woman can go ahead with the abortion and we are supposed to give her the care. So over to you, Shailja.
Geeta madam is asking, it will be a problem if you don't enter the name in admission file and discharge summary and only some code name is given. Under insurance or CGHS or Arogya Bhadrata, such cases, how to tackle this problem? Anyone, madam? Uma madam? Padmaja madam?
The thing is, what they want is that we maintain the privacy and not reveal it to everyone that this woman is undergoing an abortion. But if she asks for it, we are giving the information to her. We can as well give it. Okay. So our discharge summary will have her name and we will say on so and so date she underwent it because she asked for it. It is not we who are revealing it to the public and keeping it out. But in our records, it will be sealed.
Okay. And in case sheet also, we are supposed to put only the serial number of Form 3, not the name.
Yes.
The IPOP.
Okay. And it has been mentioned in the chat box, all the forms should be under lock and key. And remember, they should be preserved for 5 years.
Yes.
That's all, ma'am. Yeah. We'll go ahead with the third module, WHO Seva Toolkit. This will be done by Dr. Supraja. Dr. Supraja, please go ahead. Dr. Supraja, you're there?
Yeah. Let me share my screen. Can you see my screen, ma'am?
No, we can't see your screen yet.
Okay.
No.
Now, ma'am?
Yes, we can.
Okay. So, good evening, everyone. Now I'm going to discuss with you.
Enable editing, otherwise the videos won't play. You
Okay,
have
how do I do that?
a line, yellow one, toolbar on top.
You can see the enable editing line, right, Supraja, on the top?
No, I cannot.
There's a heading, the second line of
view.
Yeah.
Yes.
There's something called enable editing. You click on that.
Okay. Okay.
Yeah.
So, good evening, everyone. So you have already listened to the legal and technical aspects of respectful abortion care. And now I'm going to talk to you about the respectful aspect of respectful abortion care. So this module, we call it as the SAVER Toolkit. The SAVER means safe abortion, values, evidence, rights, and respect. So as you all know by now, respectful abortion care is a joint initiative by FOXI and WHO. So the aim of this module is to define what exactly is respectful abortion care and what are the norms and stigma and how are these norms and stigma going to affect the abortion services. And we will also provide you a WHO SAVER resources. We'll provide the links at the end for respectful abortion care. So from the first and second modules, you already know that the momentum has been created. And as we all know, the law has been changed. The law was changed on 25th March 2021, and the rules have changed on 24th September 2021. So now we have to disseminate this information, which needs association and the OB-GYN provider support. As we all know, FOXI is the largest provider base for abortion care, which consists of around 37,000 obstetricians and gynecologists. And thanks to COVID, online training is possible, and the online training is in fact easier as we can reach all the providers. So the medical method of abortion uptake has been increased, and it can be done early, it is safe, and there is also no PCP-NDT conflation with a medical method. So patient safety, respect, and quality matters more than ever, and we all have a role to play. So what exactly is respectful abortion care? It refers to care that maintains safety, dignity, confidentiality of the woman, and also ensures freedom from harm and mistreatment. It also enables the woman to make an informed choice and also continuously supporting her during and after all types of abortion. So in simpler terms, it means you as a provider or as a patient, you treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. Coming to the reproductive history, here is where most of the obstetricians, us gynecologists and obstetricians, we tend to be biased without our knowledge. We judge the woman. Not everyone, I say. We tend to judge the woman, how many number of pregnancies are these, how many miscarriages that you're going to get them done also. So this should not happen. This is where the respectful aspect of the abortion care comes in. And you have to give the entire information to the patient, and you also need to educate the woman that if something isn't right, she can speak up. There is always help available. As a health professional, it is our duty to listen and support to the woman And in both aspects, communication is the key. So what are norms and stigma? So I'm going to show you a beautiful video created by WHO regarding norms and stigma in a society. Hope it's audible for you. Audible?
Supraja, it's not audible.
Okay. Now, ma'am?
No.
No?
No. Have you downloaded this or it's playing on?
Yeah. No, I downloaded it also.
Madam, when you share the screen, no, there is in that bottom there is two button is there. Optimize for video clip. Just to click that one and once again share the screen.
So I should stop sharing and then again reshare it. Okay.
Just you click the share screen button in the bottom left side. You see the share sound and
optimize for video clip. Yeah, I got it.
Just you click that one and.
So I'm going to play it again from the beginning. Okay. Just let me know if you can hear it.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access to reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
Okay, so this is the end of the video. So these stigma and norms which you have seen till now, they perpetuate disrespect and abuse. So the various forms of disrespect and abuse are, it can be physical abuse like slapping, intimidating physically, verbal abuse, which is non-consented care, shouting, screaming, sexual abuse, abuse of power, taking advantage, and stigma and discrimination, which you have seen now in the video, failure to meet professional standards of care, and poor rapport between the woman and the healthcare provider, health system condition and constraints. So what are the rights of every woman? The rights of every woman are, every woman needs to have freedom from harm and ill treatment, the right to information, protection under the laws, which are the MTP and POXO, informed consent and refusal, and respect her for her choices. For example, if she chooses to have an MTP but not a contraception, you have to respect it and counsel her. And counsel her in every visit and their preferences. They also have right to dignity and quality of care, right to timely health care, and to highest attainable level of health. The woman needs to be at liberty, at autonomy, which means to decide for herself, and self-determination, and freedom from coercion. The woman also need to know that she can take the decision of MTP, and the opinion of the husband is not required. So this is again a repetition, but it's very important. There are 12 domains of respectful abortion care, which are being free from harm and mistreatment, the privacy and confidentiality, preserving a woman's dignity, respecting her choices, whether it's a fourth abortion or fifth abortion, you have to respect whatever she chooses and do not make her feel bad. Engaging with effective communication, soft skills, which are very important in this generation. Providing information and seeking informed consent from her, and ensuring that she has continuous access to support, enhancing the quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, and also providing her with contraceptive advice and commodity security, and continuity of care and counseling. So now it's time to strengthen the implementation of these. The important changes are, one provider can provide abortion up to 20 weeks of gestation. So the provider has more responsibility and has a room for counseling with regarding contraception and referral and compassionate care. So as providers, the onus is on us to educate the women and also reduce sex-selective abortions. So when it comes to between 20 to 24 weeks for special cases, especially these are young people, survivors of rape, unmarried women. These women need unbiased care, and we need to overcome our own biases. This is a very sensitive group of people, and we need to be judgment-free and provide them with timely services. So we also need to prioritize confidentiality and safety. As respect begets respect, as providers, we need to be mindful of the socio-cultural aspects. So the name and other, as said in the previous modules, the name and other particulars of any woman seeking abortion needs to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraception has been extended to the woman and her partner. So the main thing is respect quality and dignity at all types of abortion. So this is another video. It is a guide to avoid stigmatizing language.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high-quality medication, information and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified. How to talk about abortion. A guide to right-based messaging. Abort a child is medical.
So that is the end of the video, and this is the WHO Saver Kit. This is a short video of WHO training for safe abortion values, evidence and rights.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So that is the WHO Seva Toolkit, and these are the links for the self-paced games, which anyone who is interested, they can go through these links and go to the website and engage in this. So moving on to the next slide. I'm not audible, ma'am.
Go ahead, Supraja. You're audible.
Okay. So if any of you are still feeling bored after you have seen the videos, there are some questions which might make you interesting. So from the 1970s, the era of unsafe abortions, we have moved to 2000s where abortion was safe. And now in 2020s, abortion care has become respectful. So to make this session interesting, few questions. All of you can answer in the chat box, put your answers there. So according to the WHO, restricting access reduces the number of unsafe abortions. Is it true or false? So it's true and false, false, true, true.
This is a double negative, Supraja. That is the reason, although everyone has understood, they have said restricting. I think all of them mean that it is false.
Yeah. Restricting access to abortion care reduces the number of unsafe abortions.
So if we say very few people can do it, will there be more or less unsafe abortions? Yes, now they've got it.
Now you are getting.
Yes, now we are getting it.
Yes, Dr. Vijay Sneha said.
Yes. So if you restrict, it will never be safe.
Yeah. Because when we restrict, they'll go to the places where it's unsafe and they'll get terminated anyway.
And with in poor hands, in poor place, by poor technology. So it will definitely increase all the risks. Yes.
So let's see the answer. It is false. So when is abortion considered safe? It is safe when both criteria are met. It should be done by appropriate methods and by trained persons. As you have seen previously in the video, by 3 Ps, the provider, process, and the place. They have to be safe. So when only one criteria is met, it is less safe. And when both the criteria are not met, it is unsafe. So moving on to the next question. The MTP Amendment Act 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. Is it true or false? So, does the teenage girl who is less than 18, does she need a written consent from her parent or guardian before she can undergo a termination? So let's see the answer. It's true, 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 true.
No. The thing we are trying to say is that we are all a society where we still have children at home whom we try to protect always. But we need to remember that the world is changing. And if it is a minor who is undergoing, any person who is an adult, that is more than 18 years, who is willing to take responsibility and stake and sign, they might not want to reveal to their parents. They might not want to reveal to their guardians. So we don't need a parent or a guardian to sign. Any responsible adult will be enough. Is that not so?
Yes. See, if the girl knows that she needs consent from her parent or a legal guardian, she'll be afraid and she'll not come to you. So the law is that anyone who is an adult, a responsible adult, can sign on her behalf. Okay. So for a girl less than 18 years, the POCSO reporting is still needed, but the abortion services should not be denied. So we need to provide bias-free services without any judgment. Don't judge the poor girl and don't say any words which would make her feel bad. Okay, just provide the services, counsel her properly, counsel her regarding contraceptive services.
And we should look out for signs of abuse also in these people, because they will be very terrified. We've been hearing of so many incidents where very close family members or a known person is in an abusive relationship. That is what DIRA is all about. So we need to be alert about that.
So moving on to the last question. A 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? Should I tell her to continue this pregnancy? No.
So we are unanimous in that. We support women. Okay?
I got your point.
Yeah, that's amazing.
The answer is no, because we are not here to judge her. And because this is more than 20 weeks, we need to take the opinion of another medical practitioner and then decide. So up to 20 weeks, just a brochure. One RMP opinion is required. Between 20 to 24 weeks, 2 RMP's opinion is required. And for birth defects, there's no limit, but the board decision is needed. So this is the end of the third module, which is the WHO Saver module. And if anyone who wants to know about the Saver toolkit in detail, there is an entire 2-hour course on the WHO website, which you can go and look at. And so in India, abortion is legal, and let us make it safe and respectful. Samarth is safe abortion made available respectfully throughout the health system. Samarth Bharat and Sampurn Bharat. So thank you all for your patient listening.
Padmaja madam?
Yes.
I relogged in. I lost the matter in the chat box. Can you please address the questions in the chat box?
There were no questions. It was basically POXO applies even if she is married but less than 18 years. Dr. Uma has already commented on that. We did a very good job with answering the questions. So we had a very interactive session, which you missed, Sailaja.
Yeah. Okay. Thank you, Dr. Supraja. That was a simple and clear description of the WHO Saver Toolkit. And now we'll go ahead with the fourth module, that is the pre and post-abortion family planning counseling, leveraging technology for referrals and online consultations. Dr. Uma, go ahead.
Can you see the slides?
Yeah, we can see the slides, but we need the full screen, ma'am.
Oh, I don't know why full screen is not coming. It's on full screen here. Can you see it full screen?
No, ma.
We can see the slides.
So shall I do it again?
Yeah, please. Can you share? I wouldn't share this.
You're going ahead, Uma, you can see?
Yeah, please, Padmaja. Thank you. So after 1.5 years of this program, now we have come to the almost near end of this program. In this module, we will be discussing the most tough task, we encountered during a practice on, how to counsel about the pre and post-abortion family planning services. So this module will be discussing, we will be discussing about pre and post-abortion family planning counseling and leveraging technology for referrals and online consultation. So basically about the various family planning aspects and how to use technology to adapt to current and changing trends towards online consultation. First, how do we define counseling? Counseling is structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Now here, remember, a most important point is that the patient voluntarily seeks help from you. And so you should be open to discussion, and she should also open up about her feelings and thoughts about various aspects that we discussed during the counseling process. So what is pre and post abortion counseling? We should note that pre and post abortion counseling is integral part of comprehensive abortion care services and is as important as procedure itself. This counseling should be focused towards helping women take decisions about MTP and the family planning methods available. And if the method not necessary, and if needed, it's not necessary to involve a husband or a partner, but if needed and whenever you feel, a partner should be involved in counseling to maintain synergy and move on from there. So, what are the aspects of pre-pregnancy counseling? Next, should help women, your pre-pregnancy counseling should help women about to make decision about termination of pregnancy, help women to choose methods of termination of pregnancy if she decided on termination of pregnancy, discuss about the various methods like medical, surgical, and ensure delivery of complete information about the procedure she chooses. Help women to adapt a contraceptive method after termination of pregnancy. During the pre-procedure or pre-abortion counseling, it's your responsibility to ensure privacy and confidentiality throughout. We as a doctor should not be judgmental and always be sensitive to patients' needs and concerns. Build confidence and try to establish rapport and build confidence in the patient. Don't use any medical jargons during your counseling sessions. Do your counseling in simple, plain language and give her time to allow women to ask questions. Clarify her doubts in the form of open discussion. That is, that's exactly what is counseling by definition. And lastly, once decided on termination of pregnancy and the method of termination of pregnancy, assess her and provide her the necessary procedure for termination of pregnancy. Other issues you need to discuss during peri-abortion period is about family planning. You have to inform her that there will be a quick return in fertility. Some women do conceive in the next cycle. So a quick return in fertility after termination of pregnancy has to inform to her. Seek this opportunity or this time for contraceptive acceptance. Suggest a minimum of 6 months gap before next pregnancy by thorough counseling, and also explain her about the health benefits and better future pregnancy outcomes if there is a pregnancy gap. This is for us to note that 90% of abortion-related maternal mortality can be prevented by ensuring contraception. That is why it's also important to discuss about the family planning services available during the peri-abortion counseling sessions. So pre-abortion family planning counseling. So when do we start? You can start it during the first visit as the patient comes seeking help for termination of pregnancy, except when there is some amount of grief involved. In that event, you can delay the discussion about the family planning services. So what do you counsel? You have to counsel her about the basic physiology of quick return of fertility, maybe in the next few days to a few weeks, and also discuss about the various family planning services or family planning modalities available. Help her with the choices, and if she decides, counsel her about the method specific counseling and explain her about the high risk behavior if you feel that in a high risk environment wherever it's applicable. If the woman is not willing for any contraceptive method, do not refuse MTP. She has MTP is her right. You can offer MTP. Do not refuse MTP, but you have to take one more session to counsel about the contraceptive method after MTP. Try and counsel her after the procedure. If she's still not willing, call her for follow-up visits in a week's time and counsel. And as I have mentioned, whenever necessary, do involve the partner during the family planning counseling services. So what are the general guiding principles? Next slide, Padmaja. What are the general guiding principles or rules for suitability of post-abortion contraception? First you have to ensure that the abortion process is complete. There is no evidence of sepsis or no retained products of conception. No injury to any genital organs if she had undergone surgical evacuation of products of conception. Ensure that there is no fresh pregnancy in event there is delay, from termination of pregnancy. And coming to the post-procedure counseling, next slide. During the post-procedure counseling sessions, ensure woman has understood the precautions and the care she needs to take during the post-abortion period, when she has to report back. Just tell her that she has to report back if she has fever, or if she has foul-smelling vaginal discharge, or say she has severe abdominal pain or heavy bleeding, or when exactly she has to report. What are the warning signs? Take opportunity to counsel for contraception in case not previously accepted, and also reinforce the need for continuing the need of use of contraceptive method chosen unless she wishes to become pregnant again. So she wishes to become have a child again. So during the post-abortion counseling, it's the same procedure. Continue to ensure privacy and confidentiality. Reassure her in case of any problems after assessing, and if you feel that she's only anxious, just reassure her. Repeat the information about post-procedure care and danger signs, and take an opportunity to counsel again about family planning services. Coming to family planning counseling as such, if she has already opted, appreciate her. Choose the method, help her choose the method if she wants, discuss about IUCD or the progesterones, the pills or whatever. Help her about the procedure specific counseling and help her make a decision. Follow protocol should be in place as to it all depends upon what contraceptive method she chooses, and the continuity of family planning services or continuity of care should be a protocol to provide continuity of care should be explained. Any questions should be answered. Provide her with the information leaflets or the websites where she can get information, more information about the family planning option she adopted. If she's undecided and is anxious, allay her anxiety, give information, services and sources, discuss importance of immediate adoption of contraceptive services. If she's still anxious, schedule her another visit, and if she hasn't accepted any contraceptive method, at the least discuss about the emergency contraceptive pills if nothing has been accepted. And again, whenever deemed necessary, involve couple. Now, we'll just briefly go through the various methods currently available, when it can be started after first and second trimester termination of pregnancy, and what additional information you need to provide for each method. Starting with condoms, they're commonly used method of contraception, and even after first and second trimester termination of pregnancies, they can start using condoms immediately as soon as they resume sexual activity. The major, you have to, not only discuss about contraception, also discuss about the additional benefits like no hormonal side effects, can be used without consulting a healthcare provider, easily available, and an additional benefit of prevention of sexually transmitted infections, including HIV, especially useful for women with high-risk behavior, enable men to take responsibility of contraception. So the cheap and easy method of availability without much of help from medical personnel. The second method is intrauterine contraceptive device, whatever intrauterine IUCD.
Madam, we can see some black boxes which are obstructing the complete view of the matter. Padmaja madam?
I don't know.
Padmaja madam? Padmaja madam, are you there? Yeah. Now she has removed it. Okay, madam, go ahead.
Intrauterine contraceptive device, like if the IUCD 380, 275, 375, whatever IUCD they chose or you insert. After first trimester abortion, IUCD can be inserted immediately or up to 12 days after confirmation of a completed abortion using surgical method. With medical methods, insertion up to 15 days can be provided after complete expulsion of products of conception is confirmed and risk of presence of infection or any other contraindication is ruled out. Post second trimester abortion, IUCD can be inserted immediately or up to 12 days after the procedure is complete and contraindications like sepsis is ruled out again. What additional information you provide after IUCD insertion is that you have to provide about information about the effectiveness and how long she can actually use the device. IUCD 380A for 10 years, 375A for 5 years. IUCD can be inserted by any trained medical personnel or even an ANM or nurses. And later on, you should inform her that that doesn't interfere in any sexual activity and there is immediate return of fertility upon removal of the device and no hormonal side effects. Next, coming to contraceptive pills, oral contraceptive pills. Oral contraceptive pills can be started immediately or up to 7 days after abortion using surgical method. With medical management, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of complete abortion. Post second trimester termination of pregnancy, it can be started immediately or up to 7 days after abortion. Now here we are talking about combined oral contraceptive pills. It has an additional benefit of regulating menstrual cycles. Again, no interference in sexual activity. Can be provided by all healthcare workers after first screening by trained provider. Offer protection against ectopic pregnancies, endometrial and ovarian carcinomas, and these are the additional non-contraceptive benefits of using oral combined contraceptive pills. And one drawback is that this is not suitable for women who are breastfeeding babies and who are less than 6 months old. So in that event, you suggest them progesterone only contraceptive pills. Next. The next hormonal, family planning contraceptive modality available are the long-acting contraceptive injectable progesterones, like medroxyprogesterone acetate injection. After first trimester of pregnancy, termination of pregnancy, DMPA can be given immediately or up to 7 days after surgical method, and with medical method, it can be started on day 3 with the dose of misoprostol. Coming to post second trimester termination of pregnancy, again it can be given immediately or up to 7 days after abortion. Again, additional information is that it's highly effective, no estrogenic side effects, offers protection against ectopic pregnancy, ovarian cancer, hardly interferes with the quality of milk or no interference with the quantity of milk definitely, and confidentiality and privacy is easily maintained, can be provided by doctors or ANMs and nurses after initial screening by a qualified practitioner. Next. So, and the permanent methods, of course, yes, we have to discuss about the permanent methods of contraception too, but we have to tell them that it's a permanent method of contraception and they can't take it back whenever, like other temporary methods of contraception. Vasectomy, of course, can be performed and it is independent of the timing of termination of pregnancy, but only thing you have to tell them is, only thing they have to tell them is that they have to ensure that there is zero sperm count before, they think that it's safe without using any contraception. Now, about female sterilization, after first trimester can be performed after any abortion in the absence of any infection or severe blood loss, concurrently either by mini lap or laparoscopy up to 7 days. With medical management of abortion, it can be done only after the first menstrual cycle. Now, after second trimester of termination of pregnancy, mini lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended after second trimester termination of pregnancy. You have to inform them that it is a permanent method of contraception, inform them about the effectiveness and other benefits. There are definitely no long-term side effects, no effect on breastfeeding. But only thing is it has to get into their mind that it is a permanent method of contraception. So yeah, this is just a flow chart as to when you can start each method of contraception, as I have discussed earlier, just in a calendar form. Let's move on, Padmija. Yes, next. So, what are the other how can we use technology for the sexual and reproductive health services or to provide termination of pregnancies? So, so COVID has taught us, how to use teleconsultations or teleguidance, telereference or whatever. And I think these are here to stay with us. Now, everybody is well versed with websites, got information from the internet, and they all know how to use social media. Lot of helplines are available along with patient education leaflets and platforms on various websites like WHO, Ministry of Family Welfare, RCOG, ACOG, and a lot of patients do get some printouts about, various medical problems which they feel like they can search. So what are the strengths and weaknesses of teleconsultation or distant consultation? Strength, COVID has taught us that it's how important it is in going to, and it is likely to stay with us. It is approachable, accessible, accessible to patients and can get confidence about accessibility without thinking much about, the logistics on how to travel so far or all these things. Now, most of the population are well aware of these, these teleconsultation services. And what is the weakness? Obviously, we miss the face-to-face, like we miss the physical conferences. We miss face-to-face, direct consultation with the patient. And of course, if there is a situation where you need to demonstrate something, obviously you can demonstrate on the teleconsultation services. So, but then, there is an opportunity that patients anywhere from anywhere can access the services and ensure privacy and comfort, decreases the number of visits to the hospital, and definitely cut down the costs. Only major threat is, about the misdiagnosis. Sometimes it can be a missed opportunity because we don't see patient directly. So what is how can we apply teleconsultation services or these technology during comprehensive abortion care services? Initial assessment, confirmed diagnosis, and counseling about the contraceptive needs and the termination of pregnancy, probably a physical visit, and further additional counseling sessions can be done via video consultations, and follow up as needed, maybe a check scan to see if it's complete or not, can be again a physical consultation. So can be in a kind of a hybrid mode of consultation, a hybrid mode of services are more much better to provide a comprehensive abortion care services. Maybe with this number of visits can be cut down from one visit sometimes, or up to 3 visits if there is medical method of termination of pregnancy. So what is the key message that we give? That every termination MTP provider should realize the need for post-abortion family planning services, and it's extremely important. We bring couple on board if necessary to strive 100% coverage of family planning services, as we all by now realize that unsafe abortions from unwanted pregnancies is the leading cause of maternal mortality. Capitalization on the basket of family planning modalities available and applicability in the post-abortion period as appropriate is very important. Use technology as far as possible to provide scope for comprehensive abortion care services. Now, main concern of use of technology is about the policy. Now that there is policy about the terms and conditions in place as provided by Government of India, so we have to be strictly following the policy of teleconsultation services. It reduces the service cost and increases access to the patient. And regarding malpractice, onus is all completely onus to ensure that these kind of practices are not done. Malpractices are not done. About the adolescent reproductive health needs, again, you can make it as a hybrid, both online and offline. So we as a gynecologist, it's our responsibility to provide safe termination of pregnancy, follow rules governed by the law, and also ensure that the couple are well aware of the family planning services available in abortion. As far as possible, use technology and bring a hybrid mode of consultation services whenever needed. Thank you.
Thank you, Uma Madam, for that clear explanation about the pre and post-abortion family planning counseling and the teleconsultation part of it. I have put up the post-test and feedback link in the chat box. All of you, please copy and paste that in your Google bar, and then you can leave the session and go through that link, complete your post-test and feedback. If you leave the session, you might get a pop-up also. Through that pop-up also, you can do the post-test and feedback. But if you copy the link and paste it in your Google bar and do through it, there won't be any time limit to it. You can do it and take some time, because the back-end team have to close this session. We can't stay in this session indefinitely. And somebody asked me, what can we do if we have an emergency in the middle of the meeting? You have to attend at least for 1 hour, madam, and do the post-test and feedback through the link which we are giving you. Then you'll get the certificate from WHO and FOPSI.
Shailaja attended almost more than 1.5 hours.
Madam, you can go through the link and submit it. You'll get the certificate.
Where is that link? It is provided in chat
Put
box.
it in the chat box, madam.
So even at 10 o'clock, 11 o'clock, can I do that one?
Yes, madam.
Yes, madam. You
Yes,
just
madam.
copy that
Anytime
link
you
and
can
keep it,
Emergency,
madam.
phone calls and all. NRI and all. Okay.
No.
Madam, that link is in the chat box. Just copy and paste it somewhere so that it stays there. You can do it anytime.
Okay then. Okay. Thank you very much.
Thank you. And we finished on time, Shailaja. Thanks, Uma, Supraja. And if we continue to...
Shailaja, is it completed, the session?
Yes, madam.
Yes, madam. The session is
completed.
So how much time it takes for 4 steps, 5-10 minutes?
Yes, madam. That's it.
So is it in the chat box we have to complete or pop off? It
No,
will
no.
come.
No, we need not complete in the chat box. You